also issues around, forcing pregnancy. And so if you're forcing pregnancy, then that means you're not able to practice prevention at all anyway. Another part of the power wheel is intimidation. And some of that we can see right there on the wheel, what that means: making you afraid, throwing things, destroying property. The vulnerability to HIV comes in that, and this is interesting, that women actually learn to use sexual acts as a method of defense to avoid those other threats, right? So if giving in to sex is what will prevent them from throwing, the chair through the window, then that's what I do. But that increases my vulnerability to HIV. And it sounds like real common sense, but most times, because there's this huge disconnect between risk perception, right, and risk behavior, we're still trying to wrap our heads around that, particularly when you talk to women in the United States, women who are of African descent, and you tell them that, you're 23, 25 times more likely to have HIV than any white woman in this country, that you can have one partner your whole life and you're more likely to have HIV than someone who has 20 partners. And there are lots of reasons in that, in terms of concentration of the epidemic in our communities, and the fact that we choose partners within our own race more often than in our own communities more often than not, that those kinds of things are also structural or social factors. But the other part of it is that if we're not helping women make those connections, then that disconnect will continue on, and we'll just continue to see the epidemic rise. Does that make sense? So when we're doing when we're offering up the HIV vulnerabilities as a part of the power and control wheel, we're starting to chip away at that particular disconnect between risk perception. Because we've got a lot of folks who are in violent situations, but because they might be middle class, they might have high profile jobs, that they don't see any level of vulnerability to HIV in their lives, but then they're married to a pastor who won't tell them about their HIV status because they're having unprotected sex with other people. And here's a woman of stature who's abused, but doesn't connect her abuse to her HIV vulnerability, and lo and behold, she's HIV positive.
UNICEF, United Nations Chair of the State of Florida for GFWC, UNICEF has a program, and I have a pin back in the room, of medication to give to pregnant women, preventing the transmission to the newborns. Do your women ever get that medication?
No, everybody does. That's a very good point. For women in the United States, the intervention, which is one of the earliest and most successful structural interventions we've ever implemented, was preventing mother-to-child or parent-to-child transmission. And what we know now is that if a pregnant woman takes her antiretrovirals or takes an elevated level of antiretrovirals during pregnancy, elevate at the time of birth and delivery, that we're reducing the prevalence of HIV transmission from mother to child in the United States down to almost zero, almost zero. So that's why that particular intervention, as it has been implemented in the global south, in other countries, has been tremendously successful, where almost no other interventions would work in terms of protecting children and the mothers. So you're absolutely right on that one. And that right now, that's the only place where it's not mandatory, but it's the first place, and that meaning in obstetrics and gynecological care in terms of pregnancy, labor, and delivery. It's the only place where HIV testing has been routinized for almost 15, 20 years, right? Meaning that every woman who tests pregnant gets an HIV test. And if they get an HIV test and they come back positive, then they're referred into specialized OB or high-risk OB care so that they can get that preventive regimen, right? Yes, ma'am.
I was just going to add that even that routinization of testing isn't foolproof, because even in the last year, I think there have been 5 babies born with HIV in the District of Columbia alone.
DC has a unique issue. DC has a unique issue where I can't remember how many hospitals it was, but they just, when you all just did that population-based surveillance now, DC is one of the only cities in the United States that actually knows its population, that knows its surveillance on HIV. Most communities don't know their local surveillance, right? DC does. What they also discovered was that I think like out of 11 hospitals, more than like half of them were not doing routine testing in antiretroviral care for pregnant women, which is like, say what? So that, I think that's probably still a part of that lingering problem that is slowly being fixed in Washington, D.C. You're absolutely right about that. I'm also concerned about women who get care in the private sector, that they don't always get tested, and they certainly don't always get reported, simply because the insurance factor is extremely important. And not only do you know, we actually consider in some cases pregnancy a pre-existing condition. I saw a man with a bumper sticker the other day that said, my child is not a pre-existing condition. That not only is pregnancy a pre-existing condition, but if HIV comes back, then it actually jeopardizes a whole lot of things, potentially in terms of insurance coverage, sometimes jobs. All of those kinds of things are really important. So women in private care actually have other vulnerabilities as well. So if you went on down the line, like male privilege, the HIV vulnerability at this phase, right, that in terms of male privilege, we've got religion, we've got culture, we've got tradition that men use, right, as a way to control and exact their power. But because it's culture, because it's tradition, because it's faith, women also buy into it. Women also believe it and protect it, actually. That's what, you know, I hear so many times that, here you go, I hear so many times about, you know, the multi-generational witnessing of violence, that there's still young girls and young women who say, I just thought that's the way it is, because that's the way it's been. I didn't know it could be different. And that's really, really telling in terms of when we're talking about HIV vulnerabilities, if women don't even know the zero tolerance that some of us in the feminist community have come to around violence, that's not even a reality for them. And bringing that forward is also a watershed moment in a lot of the work that we do. So whether it's tradition or culture, or just anything around male dominance and around masculinities, that we have to also talk about that. So we end up talking about gender when we don't even mean to, because that's another thing. The assignments of the expectations based on the shape of your skin, you know, versus the color of your skin, based on the shape of your skin, are very important issues that we help women understand can be different. We all know about the economic abuse in terms of withholding funds, providing really, really small allowances, not paying for health care. I think that that's also important. And that means a woman not being able to disclose because she's still got to eat, she still needs heat, she still needs shelter and clothing. And if she's not self-sufficient and she's dependent on a partner who happens to be violent, and we also know that in many instances, batterers also have propensity to have multiple partners, right? They have a main person, the woman that they're married to or live with, but they also have multiple partners. That vulnerability alone, if I cannot negotiate safer sex with you and you're having multiple partners, then the mere fact that I'm in an abusive relationship and your risky behaviors increase my vulnerabilities to HIV. But we don't always recognize that. And these really are just very important points that we walk through these wheels with women. And just a couple of others. There's a really important situation, especially for women who are HIV positive, because there's that other directional experience we witness. That yes, if you are in a violent relationship, your vulnerability to HIV goes up so many-fold. If you're HIV positive, your vulnerability to violence also goes up so many-fold. And a lot of that can also be connected to, for example, the minimizing, denying, and blaming. So not only would physical abuse be seen from a man's standpoint of deny it, act like it's not real, you're not really hurt, I didn't hit you that hard, you'll be okay, all of those, I'm still here, all of those kinds of things. But if they're positive and they have not disclosed that to the partner, to the woman that they're abusing, then that also adds to it. So minimizing, denying, and blaming has also increased the woman's vulnerability. And the last example of that is the isolation. So when violent partners use social isolation, then it also limits women's ability or capacity to attend HIV education, to go and seek care, to get help, to have a support system or a support network that's informative and continues to bring them into services and provides them opportunities to get tested. All of these things are minimized or held back when isolation is used in the violent situation.